time together today to join us. So Lars is a cultural death care practitioner and a community organizer who's dedicated to advancing inclusive, culturally safe care for underrepresented communities. He leads the ABE or the ABE project, which is a nonprofit focused on reimagining death, dying, and grief. And he also serves as a project lead for Dignity Senior Society Inclusive Long-Term Care Initiative. This is a 2-year provincial project to strengthen and affirm care pathways for S2 LGBTQIA and older adults. His experience spans community-based hospice and end-of-life work and working with Dying for Dignity, with MAID Family Support Services, with the Callanish Society, with Vancouver Hospice, and the Downtown Eastside Community Death Care Project. He supports individuals and families and care teams through education, accompaniment, and culturally grounded end-of-life practices. So I'm sure that today we will welcome you, and we are also going to welcome Emily Watts as part of the discussion guest at the end of this presentation. So over to you.
Thanks so much for the warm welcome, Melody. So as mentioned, my name is Labhrás Quigley. I go by Lara for short and sometimes for ease. I'm originally from the southeast coast of Ireland and I've been calling Vancouver home for the past almost 16 years. I live in the south of the city along the Fraser River, and that's on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm grateful to live and do my work on these beautiful lands. So as you can see up on screen, we have the title of the project. So I'm going to just jump straight in and give you a little bit of background about Dignity and then guide you through where we stand today. So Dignity Seniors is an equity-led nonprofit based in Vancouver, and we work to support 2SLGBTQIA plus older adults across British Columbia. We partner with community members, health authorities, and organizations to create change that's both kind of meaningful and lasting. And we do this through programmings where we address social isolation, systematic discrimination, and health inequities, essentially meeting people where they're at with dignity and respect. So you can see on screen from an advocacy, resources, and collaboration standpoint where we stand. From a program delivery standpoint, we have several projects underway at the moment. The first being the Q Elders project. And this is where we shine a light on some of our community's trailblazers who help to continue to shape culture, care, and advocacy through their service. We are a family program. It's a volunteer matching program. And essentially, we bring volunteers from the queer community together with older adults for social visits, support, and shared companionship. The Social Inclusion Project, which is our newest and is running for 5 years, focuses on reducing isolation by offering outreach gatherings and events for those aging in place at home. And then last but not least, it's Inclusive Long-Term Care, which is the initiative I'm leading. And this is a province-wide initiative mapping pathways towards more inclusive homes in BC. So I have an acronym up on screen, and this one could be a little bit daunting for folks. I think I've heard it referenced to as vegetable soup at one stage. But essentially, what we're looking at with this acronym is a collective way of describing what I would call rainbow communities. And this is a way to kind of show the ways that people live, love, and identify in their lives. But it's really important to remember that when we look at an acronym like this, particularly when we're talking about older adults, it's not one single group that we're referring to, not a monolith. So every person's experience of aging is shaped by many intersecting identities. Things like race, culture, disability, class, and gender expression can all play into that. And these intersections can bring both strength and unique barriers when it comes to care and inclusion, as well as safety. So here in Canada, we often see the 2S appearing at the very front of the acronym, which you may not see elsewhere. So if you go south of the border, it's not as common. If you go beyond North America, it doesn't appear at all. And this is a way of us honoring two-spirited folks, so essentially Indigenous community members whose presence and leadership has always been part of this land and continue to guide what inclusion really means. And also when we look at the L, which appears before the G, this is a way of recognizing the leadership of women, especially their role in supporting gay men and trans women and the broader community through the HIV and AIDS crisis. So these are small but important acts of respect for the care and courage that shape so much of the movement that we build on for today. Now, a way of also looking at this from a kind of a sum up perspective is when we see this acronym, we're essentially talking about folks who are coming from a sexual or gender diverse background, so not fitting into what we'd refer to as a mainstream or normative society. To dive a little bit deeper and to give you kind of a tool that can maybe be helpful, particularly from a clinician standpoint, the framework we have up on screen is the Gingerbread Man. Some of you may have seen it previously. So this framework offers a way to think about gender as something made up of several distinct but related aspects. So we've gender identity, gender expression, sex assigned at birth, and attraction are not all the same thing. So essentially noticing these differences can help reduce assumptions in care, particularly at vulnerable points of a person's life. So each of these aspects exist along a spectrum rather than within fixed categories. Holding a spectrum-based understanding supports person-centered care and allows space for people to understand on their own terms, especially as circumstances, health, or capacity change over time. Attraction can also be experienced in different ways. Romantic and sexual attraction do not always align, and acknowledging this can be helpful when considering relationships, chosen family, and those who feel emotionally significant to someone at end of life. So in palliative settings, the gingerbread person is not about labeling or categorizing. It functions as a gentle reflective tool, supporting careful listening, respectful communication, and care that honors the whole person rather than assumptions about who or what matters to them. So also in context of the queer community, and you'll hear me reference the word queer quite a lot during this presentation. It is a word that has been reclaimed, and also to call out that not all members of the 2SLGBTQI community are comfortable with it, particularly members who are in the older or elder years, who have a heavier association with the negativity that would have come from it in the past. So when we look at the history of communities, in the queer community, a lot of times we get instantly pulled into a US kind of centric mindset or over to the UK. And I wanted to really give you a sense of the kind of recent and relative history that appeared here in Canada. So in 1969, homosexuality was decriminalized, and by 1973, it was removed as a mental health disorder from the primary diagnostic manual used by doctors and mental health professionals. So alongside these progresses, there was also deep and lasting harms. So from the mid 1970s through to the 90s, the federal government and military carried out what is known as the Purge. So this resulted in surveillance, harassment, dismissal, or forced resignation of queer people from the civil service, the military, and the RCMP. It's estimated that approximately 9,000 people were directly affected, and the impact of that lives on today. In the 1980s and early 1990s, the HIV and AIDS crisis obviously devastated queer communities across Canada, particularly in urban centres. Before effective antiretroviral treatment became widely available, many people living with HIV progressed to AIDS and died, with mortality rates in some cohorts reaching very high levels. So at the same time, this period also sparked extraordinary community organizing, care, and advocacy, and can almost be seen as the foundation of this modern death care movement that we're seeing coming out of the grassroots side today. It was all seeded during this period. In 1981, specific to Toronto, we had what was called Operation Soap. So these were bathhouse raids in which I think it was about 300 people were arrested. And these protests were followed and are widely understood to be the turning point in queer organizing history here in Canada and helped give rise to what we know today as Toronto Pride, which is one of the largest in the world. Through to the 1990s brought important legal protection with sexual orientation added to the human rights legislation, followed later by marriage equality. In 2017, gender identity and expression were added to the Canadian Human Rights Act, and more recently, Canada formally banned conversion therapy. So for folks not familiar with conversion therapy, it's a kind of a pseudoscience approach to taking folks out of their communities who are showing to either be on the spectrum, the queer spectrum, and bringing them into a space of essentially brainwashing back to a straight cis type of identity. Normally, you'll see these in rural areas, religious communities. It's quite widespread from what I've experienced from moving from Ireland to here, where many of my friends have been impacted by this over the years, particularly older generations, but I also see this in many folks in their 20s, 30s, and 40s as well. So this history kind of reflects both kind of meaningful progress, but also kind of a lived memory of discrimination and resilience that continue to shape the lives of many queer older adults today. Something else I also wanted to chat on is really about language, which is kind of always evolving. And the language you use to describe, particularly around gender, has evolved, particularly in the more recent years. So in the late 1980s, the term transgender became more widely used to describe the range of gender identities, and that's been shortened to trans. And the 1990s, Indigenous leaders in Manitoba introduced the term two-spirited as a name that identifies the roles that long existed before colonization occurred. Also, echoing my comment about the use of the word queer, two-spirit isn't inclusive to all Indigenous people. You'll find many terms from gay to indigiqueer to none at all that are used. So always remembering that each individual will bring their own perspective to their identity. And then more recently, non-binary has become more common, helping to describe identities that are not necessarily strictly male or female and fall somewhere in the middle. So shifting into a social science perspective, for any social workers online, this may be a helpful framing tool. So the cohort model was developed by researchers like Dr. Karen Friedrichsen Goldstein. I believe she's out of the University of Washington, who showed how queer older adults age with a shared imprint of their history, from criminalization and the AIDS crisis through to today's ongoing challenges. So when we look on the far left-hand side, we have the invisible generation. And when we look at these cohorts as well, they loosely align with where we would see things of like, millennial, boomers, silent generation in mainstream populations. But these are signaled more to the unique experiences of the queer community. So with the invisible folks, they grew up when homosexuality was criminalized and pathologized. Many lived in secrecy with a high fear of arrest, institutionalization, or rejection from their communities. For a lot of these folks, they're often aging alone at home, have a deep mistrust for the system, particularly healthcare, and rarely disclosed their identity. So we're talking folks probably in their 90s who are mostly aging out of the system at this point. When we shift across for folks who were born in the 1930s to 1945, so this would be my parents' generation, this is where conformity was expected. There was limited early community spaces. We didn't have queer or gay villages like you see today in some of the bigger urban areas. So many led double lives, entering into things like heterosexual marriages or lavender marriages, where you might see a gay man getting married to a lesbian. So the outward expression is normal to society, but behind closed door, they live their homosexual lives. So disclosure is really complicated, and fear remains in this age group. So even in care, when we look at the Pride generation, so this would equate closely with the Boomer generation. These are the folks who are what I would say knocking on the door of long-term care and palliative care at the moment. Many of these came of age post decriminalization, involved in early activism, not all, but built stronger queer communities and face ongoing discrimination. So they hold this kind of interesting space of kind of, equal parts pride and burnout. These are change makers who still face barriers as they head into the later stage of life. And then lastly, on the far right-hand side, a little bit of a shift in this cohort in shifting from born dates into diagnosed date. We're talking about folks who were diagnosed in 1984 with HIV up to around the mid-90s. So I'm 41. I was born in 1984. So it's folks in the last 40 years, but particularly the folks who were coming of age in the mid-80s up to the mid-90s. So they were devastated by the AIDS crisis, mass loss, trauma, and stigma were rife throughout community. Survivors also have medical complexity and system mistrust, and HIV stigma persists in care despite long-term survivorship. So shifting into a little on the statistics side, so a lot of information up on screen, and these slides will be available after, so don't worry too much about taking anything down. But around the world, typically we look 9 to 10% of folks identify as queer. In Canada and Western countries, the number typically drifts up to about 12%. And really, this kind of echoes the type of country they're living in relation to the level of freedom that exists for citizens. So when we talk about older adults, we're talking about a real and significant part of our communities. But among older generation, the numbers look quite different. So here in British Columbia, for example, there are nearly a million older adults, yet only about 40,000 or 4% openly identify as queer. We know that number doesn't reflect reality, it reflects under-disclosure. Many queer older adults haven't spent a lifetime hiding who they are to then come out in a survey saying that they are gay. And this is particularly those silent generations or invisible generations which are hidden within the system at the moment. As we kind of move on, there's generations shaped by discrimination, by loss, survival through the HIV pandemic, And we estimate that as many 60% of the cohort was lost. So friends, partners, entire communities, and that absence still reverberates in our care systems today. Um, One of the estimates I was looking at recently was by 2030, the number of queer old adults here in BC is projected to triple. So right now, kind of our work at Dignity Seniors is twofold. It's showing up for the current 4% who are visible in nursing homes, hospices, and palliative care units, ensuring that they feel safe and included in care, but also preparing the way more for those folks that are kind of arriving in that boomer or activist generation that are now approaching into the care dynamic. So when we look on the complex care and the kind of unique challenges of our community, trans healthcare needs particularly bubble up to the surface. So they face very specific challenges when they enter long-term care and other end-of-life systems. There are medical and transition-related needs that require sensitivity, for example, pericare, or the ways that dementia may impact a person's ability to advocate for their gender identity. What do you do in the case where you may have affirming staff on your team, and one of your clients or residents wakes up in the morning in their identity, but goes into a regression over the course of the day and ends up agitated and confused when they see their clothes are missing or their pronouns are not being used as the way it would have been familiar at an earlier stage of life. So a lot of these things are pretty new into the system. And one of the striking, I think, realities that kind of hit when I was researching for this project was the lack of data around the trans community when it comes to entering into our systems of care here in Canada. So I asked around in community, I spoke to seniors, which there are not many of. And also here in BC, we have Transcare BC, which is part of the Provincial Health Services Authority. And the kind of consistent story that was kind of weaved for me as I was in those discussions is the absence in itself tells a story. So many in these generations didn't live long enough to reach old age due to high rates of suicide, violence, and systematic exclusion. So the few who are now entering long-term care are true survivors, and their needs are both urgent and unique. Discrimination remains a real problem. Too often, staff and providers lack training or knowledge in trans-specific care, which can lead to poor experiences or even harm. And all these factors underline the need for culturally competent, affirming care models that ensure trans seniors can age with dignity. So I wanted to pause here, firstly, to refresh before I lose my voice, and also to kind of bring us into more of a lived experience or stories from our community. So on the left, we see a non-binary elder known as Kai, who spent their final year advocating for their basic everyday needs. The care team in their long-term care home had limited experiences supporting queer residents, and instead of being able to focus on end-of-life care, much of Kai's energy was taken up defending their identity and their rights. Kai left quite a legacy behind them in their care home with new programming, pronoun pins, and education being embedded into the organization. But I think the question really surfaces back up, is this a responsibility of the resident or for us in the system, either as clinicians or organizations like Dignity Seniors, to be carrying the weight of this work for our older and elders in our communities? On the right, we had a trans elder named Pam, and this wasn't too long ago, but they were placed in a faith-based long-term care home. And after pressure from other residents, they were forcibly transferred. In this case, Pam had reached out to us as an organization, fearing that they were going to become unhoused. And when we looked at the situation around the placement, we were like, straight away a red flag had gone up for us. We were like, this faith-based long-term care, when we understand the values of that religion, we see that trans folks are typically excluded. But based on the bed being the first available within their community, they got placed in. And we look at the impact on both them as an individual, on the other residents who come from a different value system. And then obviously the friction that comes from this case where after 6 months a transfer needs to be arranged to a new home and a resettlement has to be done. All of that could have been avoided if a more appropriate placement had taken place in the first spaces. So these stories remind us that inclusion shapes safety, care, and how people experience their final years. So aging with HIV, this is pretty new, and I know it's not covered under the general education that we folks receive within the systematic side. But in BC specifically, when we talk about HIV, it's no longer seen as a young person's disease. I think the average age in BC specifically is around 55. I think it's a little bit younger across the rest of Canada. And this reflects how effective treatment has been. It also means that HIV, as I mentioned, is no longer associated with those younger generations. We're increasingly seeing older adults aging with HIV across care settings. So for many queer older adults living with HIV, there are kind of layered challenges that come with this. So we often talk about the triple stigma of living with HIV, diagnosis, being part of a sexual or gender minority, and experiencing ageism at the same time. So together, these can kind of shape how safe someone feels disclosing, asking for help, or accessing care. So care itself is often, in these cases, also more complex. So many people are managing multiple medications, have coexisting health conditions. Some may have experience with HIV-associated neurocognitive disorder, or HAND for short, which is a type of dementia which can range from mild cognitive challenges to more significant impairment. When I looked at some of the studies which are still kind of coming out, there was a few Canadian, but mostly US. They were seeing a range of anything up to 50% of folks who are aging with HIV will have some impairment from hand. Um, the other thing to note as well, that when we look at these folks who were diagnosed with HIV, particularly in the early 80s and 90s, because treatment was at such an early stage or didn't exist, the experimental treatments that were done and the load in their systems from the medications they took in the early days really had an adverse effect on the frailty levels of the folks who are now entering into our system. So if we look at, like, let's say approximate average of mid 70s for someone to enter into long-term care, it's 10 to 12 years younger based on data in the US, where we see folks who are aging with HIV going in. So we have a younger cohort arriving in with more complex care needs, and that's something definitely to be factored in. So all of this underscores the importance of care that's not only kind of clinically sound, but also culturally safe, trauma-informed, and grounded in realities where people are living with. When we look at Canada as well, specifically around HIV, gay, bisexual, and other men who have sex with men continue to represent a large share of new HIV diagnoses. However, national estimates suggest that while new infections among this group have decreased proportionally in recent years, particularly with expanded access to PrEP, new infections have increased among people who inject drugs, Indigenous folks, and particularly women and women of color. These trends reflect ongoing systematic inequities and gaps in prevention, but also shows us that the work we do today for these folks who are now aging with HIV also create pathways for the folks who are moving through a couple of years behind. So I wanted to shift back to another story. I get to see a bit of my mug on the face of the screen there as well. I wanted to share a story about my dear friend Frank. Um, Frank and myself were introduced about 3 years ago, and he was an introduction for me to this work. My history is an interesting one in the sense that I come from the tech industry and have shifted completely into end of life work, which is a story for another day. But Frank was one of my entry points into this area. So Frank was originally from Hungary. He survived the Holocaust as a child, in part because his parents came from a mixed faith background. In his 20s, he emigrated to Canada, carrying with him a lifelong awareness of safety and belonging and what it can mean to move carefully through the world. So for much of his life, Frank was social, engaged, and deeply connected to his community. But with the arrival of the pandemic in 2020, 2021, he lost his long-term partner, was forced to downsize his home, and experienced increasing isolation at a time when connection really mattered most. Not long after this, he also got diagnosed with leukemia. So as his health declined and his care needs increased, Frank was hesitant to enter into the system, particularly long-term care. He did not want to feel that he would have to go back into the closet. And even with independent living became no longer kind of that point of meeting his needs. At times I would find Frank was almost on a bi-weekly schedule of arriving into the emergency room. He still insisted on staying at home. So for him, I think where it was really playing in was when some care aides were coming to his home and learned a little bit about him, and particularly that he was gay, that he noticed that there was a shift in the dynamic and the relationship that came. There was a distancing that occurred. You could refer to it as like almost like a microaggression. And I think when you're sitting in a place of your home being a sanctuary, and you're seeing the representative of the system is coming in and feels either uncomfortable or a disdain for you because of your sexual orientation or way of being, It really kind of speaks volumes of what you can expect if you moved into a 24-hour care situation. And, people talk, and Frank, when he talked to his community, the folks who had moved into long-term care chose to go back in the closet for their personal safety. And this isn't always reflective necessarily of what the nursing staff or the care aides are doing, but it's also the value system with folks of that age group who grew up in a very, very different time when things like misogyny and homophobia were rife in those generations. And sometimes that hasn't changed. So for personal safety, particularly when you're moving into that more frail and vulnerable stage of your life, and when community suddenly disappears, a lot of our seniors, from based on the feedback we receive and the story that Frank had shared with me, choose to go back in the closet. So ultimately, with Frank, he chose MAID rather than entering the system. He did not trust, essentially, to see a better way for him to move towards his end of life. So his story continues to guide my work. It reminds me that inclusion is not an abstract idea. It shapes how people experience care, dignity, and choice at end of life. So shifting a little bit more into what I do, I guess, and why I'm here chatting to you folks today. So when we talk about culturally appropriate care, I think the initial response I typically get when we talk about queer inclusive care is a sense of, let's stick up a couple of flags, let's put on some pronoun pins, and we're good. Pat on the back. We might do a Pride event in June. And where we're really trying to go with this project is, how do we go beyond that and go into a deepening? A lot of our community give us feedback of this sense of that pink washing aspect, that it becomes this tokenistic thing. It becomes like Halloween, it becomes like Christmas, where stuff goes up, it comes in, and then the rest of the year we kind of forget the meaning of these important moments. So when we talk about culturally appropriate care, we really mean a home that does more than meet the basic needs. It's a place that actively respects and affirms the diverse identities of the people who live there. It's about creating safety and welcome where sexual orientation, gender identity, culture, language, and spirituality are seen and honored. And it's about staff who are supported with ongoing training and cultural humility, so they can meet people where they're at and also respond to their unique needs. It's also about policies and practices that back this up, like making sure chosen family can visit and that residents are always called by their correct names and pronouns. And then also, when we look at the physical space itself, showing signs of welcome and inclusion in what people see on the walls, the languages that they hear and read, and the accessibility of the design. We had a really interesting example that I came across out of Toronto, where a care home had a dedicated wing for the queer community, and they chose to paint the walls. So when you step into the average care home anywhere in this country, beige becomes a quite prominent color palette that you'll encounter. And they took it on themselves to partner with a painting company and chose alternating walls and took the rainbow flag, broke it down, and used each of the colors to represent one of the letters. So they told the story of two-spirited folks, of the trans community, of lesbians, of gay men, and so on. One of the interesting things that they did find, though, besides adding vibrancy into a space that typically lacks, the rate of falls in their nursing home decreased. And they attributed this back to the fact that because there was now a high contrast appearing at the edges of walls and edges of things, that seniors, particularly seniors with dementia, had an easier way of distinguishing how to navigate those spaces, resulting in overall a decrease in falls. And it kind of really speaks to this work as not being tokenistic. There's generally, when we look at the queer community as a minority, the thing with this minority is that the queer community represents all of society. Like, you look in, we have folks of different races, backgrounds, disabilities. Every aspect of society is represented within our community. And so any work that we do here generally has a wider impact of kind of moving beyond that immediate circle. So I always find it's really, regardless of any inclusive work we're doing, it's always to center the experiences of queer people, because you'll find that will typically lead you in the right path for general societal inclusion as well. Here in BC, we have some examples of culturally safe long-term homes that are geared around specific communities, mostly geographic in basis. Originally, some of these European communities would have grouped together to set up these homes and are now more mainstream. We have Asian communities. The New Vista Centre, in particular, where they serve Korean food, have Korean staff, is in Burnaby, BC. And then the Louis Breyer Centre, which falls under the Jewish faith tradition but is open to all, has done extensive work for inclusion for their seniors, not just from a Jewish perspective, but also on the queer spectrum. But just to show you what we're talking about today is not something new. It already exists in our system, but tends to be niched off in specific parts rather than across the board. So, timeline, I just wanted to give you kind of a very high level sense of this project. It's a 2-year project and it's federally funded. So, we kicked off in 2025, and the focus was really on listening, relationship building, and learning alongside our homes and partners. We went out into community, we spoke to our seniors, and really wanted to get a depth of understanding of what was that journey for folks as they navigate these later stages of life. Over the year, we moved from consultation to shared learning and to identifying a small number of homes that kind of wanted to do the deeper work with us. And now, starting next month, this work becomes more hands-on. So we'll be doing supported training, implementation of, and reflection on a lot of the recommendations that we bring forward with this. So this is less about really hitting milestones and more about building something durable and trust-based that lasts beyond the 2 years, and really looking at what the sustainability of a project like this can be and how we can empower the staff to continue the work once we roll up at the start of next year. So for care homes that we're working with at the moment, we're currently working with 10 homes across the province, and we have capacity to welcome maybe a few additional here in BC. We're really looking at Northern Health. Prince George would be fantastic to get some homes, but we've hadn't had any response so far. And we have a little bit of capacity based on population in the Vancouver region as well. So our next phase is really about learning together. It's about understanding what inclusion looks like in a day-to-day practice and building on those strengths that already exist within each home. So each participating site begins with an inclusive care review. This is a reflective look at the current practices, space, and policies. From there, we work with staff and leadership through tailored training focused on queer inclusion, along with the complex care needs for folks with HIV, trans, and gender diverse care. Homes also have the opportunity to look at intake and assessment processes, including how residents self-identify. And then we invite feedback on environments and programming, looking at how spaces, activities, and communication can better support belonging and visibility. Ultimately, we're hoping to leave with a toolkit at the end of this project so any home can download and continue this work. As I mentioned before, sustainability is an important pillar of us. Measuring impact and meaning, it's important, but really for me, it's the outcomes is where we want to focus, and that's ultimately on residents having a greater sense of safety and belonging in our system, improved placement for trans and HIV positive residents, and stronger inclusion and cultural safety embedding across the system. Want to give you a summary up on screen, just some of the stuff we've chatted through. So essentially, we're seeing more queer older adults stepping forward and needing care, and that visibility comes with responsibility to make sure our systems are ready to meet them with respect and inclusion. Yet many still face barriers, stigma and discrimination, or just the fear of not being safe, all of which lead to isolation and poor health outcomes. Within this, some groups are particularly at risk. Trans seniors often face unique medical and legal challenges, and older adults living with HIV still experience layered stigma and complex care needs. The tools exist, like the inter-RI assessments, but they're not always used in ways that ensure affirming placements or culturally competent care takes place. So the path forward for us is clear, in that we need to do ongoing staff training, improve our policies to be more inclusive, and make a real commitment to cultural safety. Some of the resources I have up on screen, I'll just skim through, but they were very useful in the research aspect of here. Tapestry in particular at the top was a project that mapped diversity and inclusion resources for long-term care homes. A little bit of a BC focus, but I think it's universal across Canada in most cases. And then when we look specifically into areas like trans and HIV care, Realize has an amazing course online for nominal charge that will guide you through more of the complex care needs. Transpulse Canada has some great research, and Transcare BC has some great clinician-ready downloadable support forms that you can incorporate into your existing workflows. So I'm going to shift a little bit now from attention on myself and my side to introducing Emily. Emily is a friend and a colleague, I could probably say at this stage, who we've been working together the last few months to share news on this project. Emily has agreed to join us for 2 questions to kind of kick off the Q&A portion. And after that, well, as I said, we'll move to more open pieces. So Emily, if you're there, let's see if we can get you up on screen. I might lose you in a sea. There you are. Perfect. And I'll see if I can pin you. So hopefully that can help for folks to see. But just to kick off the questions, obviously lovely to see you, Emily, and thanks for joining from Vancouver Island. Do you want to give us a brief introduction before we jump into the questions, and then we can go from there?
Yeah, absolutely. So my name's Emily. I go by she, her. I am a registered nurse working on the island here, as well as a trans woman. And so I worked with researchers creating the first of its kind 2S LGBTQIA liaison role. I'm a forensic nurse. I'm a sexual health nurse. I'm an urgent care and emergency nurse. I do a whole lot of things. And hopefully, as of September, I'll start doing my nurse practitioner. So that's who I am.
Fantastic. So all the nursing,
Yeah.
essentially. Um, so Emily, obviously we had a chat before we came online and we were trying to devise some questions that might help to translate from like the perspective of myself in a nonprofit who's working into the system to someone like yourself who's actually in the system, has lived experience and also sees the journeys of many of our patients that we don't see from the outside. So the first question I had was from your experiences, what helps older 2S LGBTQIA people feel safe enough to share and really matters, kind of knowing your end of life and what gets in the way?
I think the biggest things, I mean, having other community around, having community members working in a facility makes a big difference. It always just reduces the barriers, even at, I mean, at any stage of life. Having providers that are not only trained in providing affirming care for people's identities and sexual orientations, but also are capable of being allies. So when they see something happening, maybe between residents or between a colleague, they have the knowledge to safely intervene where appropriate. And I think that the struggles that we sort of see are, I mean, essentially not having that education, but people being isolated from their communities when
Mhm.
they're in healthcare facilities is really the long and short of it. I think is the biggest thing, and I could say that myself. Maybe not in a long-term care facility, but in a being hospitalized in Quebec and not having any of my community around, not speaking very much French. It's very isolating. It's very scary in an already sort of um, uncomfortable
Mhm.
situation.
Thanks for sharing all that. And then I think when we look as care kind of increases for our older adults, what are a few practical ways clinicians can ensure partners and chosen family members are respected and not unintentionally sidelined through those processes?
Yeah, I think that the biggest thing is ensuring that that conversation happens early on. I think that what I see often is people are nervous to engage in a conversation with a patient from the queer community about their family, about their needs, and about their culture, and then it sort of progresses to the point where we're pretty late in the like death and dying process, for example, and then we're trying to have that conversation. So building that into the care plans early on, who's going to do what for that patient, who needs what information, um, uh, all of those things. And so really care planning it, I think, is the biggest part I could think of.
Great. Thanks for sharing on that side. So one of the things we wanted to shift to as well is when we were looking at the registration list, we noticed the heavy leaning on the clinician side. A lot of nurses were joining, some maybe for the recording, and we wanted to give a space to support with questions. We have, I think, about 18 minutes left. So if anyone's interested in putting questions forward for either Emily, myself, or on the project, or just case scenarios you may have seen, we do welcome them. Encourage you to put your hand up and we'll try filter that way. I haven't checked the chat so far, but we can also look through that. And Melody and Tina will be supporting us on the BC Centre side as well. I got to stop share just so we can see our faces a little bit clearer as well. And yeah, so I see Laura Wang. You're on mute.
There we go. Sorry about
That's
that.
all good.
One of the things that always jumps to my mind is the temporary substitute decision maker default hierarchy and how much that doesn't fit everybody and how sort of heteronormative it is, and it drives me crazy. And I wondered if obviously there's a process when you're going into long-term care or even going into assisted living where you're having a conversation about sort of a care plan. And I just wondered if there's any thought to incorporating a discussion about a assigned substitute decision maker. If someone doesn't have a representation agreement, is that discussion happening? And I don't know. So I'm curious if that's part of what you're educating about or if that's a change that you're looking to make, because I don't think it's consistently done.
Absolutely. I can say from the project perspective, Emily, you may have feedback from the internal side as well. One of the things we do at Dignity Seniors as well is have an end of life working group. So we've been working on putting an advanced care planning guide together, really with these considerations and exactly what you're talking about, that kind of hierarchy that defaults. And unfortunately, with advanced care planning, with everybody in society, we're very behind in documenting our wishes. But this becomes acutely aware for the queer community when we end up in situations where it needs to be used. And many times it's defaulting back to a biological family, and there's a huge volume of estrangement, particularly with family members around what that may look like. So what we're hoping with this project is that we do offer that aspects to residents who do sit on the queer spectrum to sit with them and go through advanced care planning as one of the workshops and programs that will incorporate into their care plan. And then as a longer term plan for Dignity Seniors is to have a downloadable guide on our website that can be a resource for anybody in BC or across the country, just with those considerations to put in place, particularly when you're referencing chosen family. How about you, Emily? Is there anything on the internal side?
Yeah, I think that all of what you said is great, and we need it. I think that to echo what you're saying, I don't think we do a great job at not only talking about advanced care planning for all populations, let alone where that gets shared. Um, so yeah, I think having some sort of conversation around that, especially for this community. We're lucky in Canada that we have, same-sex marriage and all of that, which does help to a degree. But if you're somebody that doesn't have a partner or that partner's passed away, and you're left with just your family, I would probably rather have some of the closest people in my life making decisions rather than some of my family. So including that. From my perspective, from like acute care or community care, um, I'd also love to see that that gets transferred to us more, especially for this community. The whole care plan, like if they're coming in to emerge, we know who that decision maker is. We know that that's already been discussed. We know what their name that they go by is, their pronouns, their chosen family, who to contact, because that may not always be, um, in an emergent situation. Often that is really difficult to track down, and I've seen that go wrong.
Great. Thanks for the question. Monica, great to see you.
Thank you. Always happy to join. Curious, looking forward to when the toolkit will be available at the end of this project. But is there anything in the interim as far as staff ensuring that all residents moving into long-term care feel comfortable, feel confident to be their true selves? Has there been kind of any preliminary pieces that you guys feel would be helpful nuggets of information for our staff to express that openness in whichever LTC the person's living in?
Hmm. It's the Interright forms are interesting because there's obviously Interright is in the process of rolling out updated sexual identity and gender markers on their forms. And I think if I'm correct, is it Vancouver Coastal, Monica? I think are you folks rolling it out at the moment? And
I
yeah, it may not be.
honestly, I don't.
No worries.
I'm not 100% sure. I don't do the riot in
Uh,
LTC,
n-
even if I work in
n-
LTC.
No worries. For folks not from BC, there's five health authorities here, and they're all rolling out at different times. But I think the aim is by the end of next year across the country, the Inter-Right forms should be standard for placements into long-term care. One of the things was missing was a place around where does somebody who doesn't identify as male or female and on the trans spectrum, how do they identify? So those marker boxes have been put in. The tricky, I think, with markers and forms and data collection, and I think I echoed this from earlier in the data collection where we saw only 4% of the citizens of BC identify as queer. It's trust in the system, and when you put a mark on a form, what does that actually mean? And if we look at this again through history, it's like, you go back to Nazi Germany, and as we're all very familiar with the Jewish story and the concentration camps, but the Roma, the Sinti, and queer populations, the same thing occurred. And how it happened, because it was pre-technology back then, was we all carried around little notebooks with our contacts in it. So when they would arrest, let's say, a gay man, they would then go through the address book and then reach out to each of those individuals and interrogate them and essentially round them up that way. So when you put a marker to say who you are and you share that information to government, that can cause a lot of unease for folks. And then when we look at a Canadian perspective, right up onto the mid-90s with the Canadian government purge, we have so much recent history that tells us this is not a safe thing to do. So we have this aspect where the form's ready for that, but it's really about how do we look at the visibility as residents move into these spaces. Inclusivity is so much more than a flag and so much more than a pronoun pin, and people energetically feel this when they walk into a home. And I've had experiences of this myself, and I'll share, which is slightly unrelated, but just to give you a sense of what I mean when I'm referring to inclusivity. I was giving a talk at a church about MAID about a year and a half ago, and I haven't been in a church. I grew up in Ireland, Roman Catholic kind of background, and as most people later in life push away from the institutional side. And I walked in with just kind of, that expectation. My body was going to tense up. I'm going into a place that's a little bit austere. And I walked into this church, and the first thing I noticed was the warmth. So the heating was on, which was a new thing for me. But also when I looked around, when I looked at the furniture, as opposed to rows of uncomfortable seats, they had larger than average single seats that were cushioned. So they were made for all bodies, like bigger bodies, small bodies, but it was about comfort and individuality. And then while I was waiting for somebody to bring me in, I was walking around, and I remember seeing on the left-hand side, churches typically have that shape of a cross architecturally. The left-hand side had been soundproofed off, and it was made available for families. So if you had kids that were being disruptive, toddlers that are climbing around the place, you had a space that you could still be included in the service in here, and then your kids had something to do and to play. When I went over to the opposite side, they had a library, and I was expecting it to be religious books. And the first thing I saw was all these environmental books, all these books on BC, then all these Indigenous books, and then I saw a whole wall of queer literature. And I was like, oh, I can see myself in so many of these books. I would happily spend hours here. And then that's just even before I meet any staff who then are like, come in and give a talk, and I meet the folks. So there's all these cues. So when we talk about that, when we talk about the system, this could be if you have a private long-term care home, this could be how your website's reflected. What are the images you're showing? What is the welcome signs as someone walks into your reception? Who's doing the onboarding? Who's actually greeting the person that's coming in? Who's doing the intake? What are their soft skills like? What are their cultural humility training aptitudes like? All of these play such a big part because, as I said, you can stick rainbow flags on every single wall, but if you know it's not a safe place, you'll feel it in your body pretty quick. So I share that more of the sense of, I think we need to get beyond the tokenism of symbols, and symbols can be really important and they can be wayfinders for people. And it's not to say to get rid of them, but I think it's really how do we go into that deeper sense with our staff that make people, when we get to like into right form and come to tick a box, that they know it's safe to go, yes, I'm part of this community. And then when that information is collected, what do we do with it? Do we just tick a box, input it in the system and never to be seen again? Or does that activate an internal process that says, hey, we should be considered if this person is sharing a room, maybe we need to ensure that the person in that room is also safe. So there's all those kind of knock-on impacts. So with each of the care homes we're working with is really looking at their unique circumstance. Some are owned and operated by health authorities. Some are private with public funding for some of their beds. And each of them have unique populations that go into them. And it's really taking each situation as unique, but also mapping out what is the journey of somebody. What will this look like when 75-year-old Lar is being kicked out into a nursing home? What is my journey? What's the seat I'm going to sit in? Who's the person I'm going to talk to? Where am I going to be brought in the space? Who am I going to be introduced to? When I look at the programming, that's happening in the week, do I see myself reflected, or do I just see an array of copy and paste programs that go from one home to another? So these are the areas I think where we need to think a little bit deeper and bring that sense of compassion and empathy in, where what would happen if you were in their situation and how could we relate there? The other aspect that I want to talk about briefly, and it actually connects to the role that Emily was doing with Island Health, and it's really around these liaison roles. So here in BC, we have liaison folks in the Indigenous community. So if you step into an emergency room or anywhere in the hospital system, you'll typically see signs up on the wall going, if you're a member of the Indigenous community and you need help or you're in distress, please call this number and somebody will be paired with you. And I think when we look at Emily's role that was in Island Health and got approved and had 2 great years and lots of great success, was our community also needs these supports. And if we had a space where, somebody arrives into a nursing home and they can just see on the wall that, hey, there's just somebody who can champion you when maybe your chosen family have moved away, you may not be connected to your biological family, you're in a frail state of life where you may not be able to defend yourself from a physical standpoint, to know that you have someone at the end of the phone that can arrange a site visit, I think that goes so much further in relation to anything that can be done from the process standpoint. So I'll stop my my rant there. But Emily, I don't know, do you have anything to add on that side?
No, mostly just that I agree. I agree that having a liaison role, like we've seen in the data, that people from the community feel like 80 to 90% safer, more likely to access care when needed, like all of that, which is huge. And just again, I've heard a lot from even just my generation kind of making comments about like being uncertain about whether like electronic charting and getting adding your name and pronouns there, like who's going to have access to it. And I think that we've got good data policies in BC, but at the same time, we right now we live in a time where you look to the states and the federal government is actively trying to get the information from hospitals about who is trans, and so people right now are definitely thinking twice about whether identifying themselves as a part of this community is a smart thing to do, which I totally understand.
Good. I see another familiar face. Wade, nice to see you.
Hi, Laura. Nice to see you. Thank you and Emily for all of this. The question I have, so clearly the clearest entry point for making long-term care more welcoming is with like the staff and the facility, but I wonder if you're learning about practices for working with other residents, and when there are challenging behaviors and dynamics, and whether that's generational dynamics, whether that's cognitive and behavioral dynamics. And we see this with other behaviors and residents who are really like misogynistic or sexually inappropriate, and so we make specific care plans to be like, okay, who's caring for this person, how do you set boundaries with certain kinds of personalities or cognitive ranges, all of that. So I'm wondering if you're learning anything about that for creating safety for the queer community.
Emily, do you have anything on from internal perspective?
Yeah, definitely. I think that this needs to be done. We need those care plans, but I also, yeah, I mean, a lot of the time it's going to be if somebody has a history of violence towards this community, and maybe we don't find that out right away, and sometimes it comes after developing dementia or Alzheimer's or whatnot. But it does happen, and so finding a different unit for that person to be on so that the other individual is safe often is the best solution. As clinicians, because I've had this situation come up in acute care where an individual with this history was transferred to a unit that was mostly younger individuals, and a big percentage of them were from the queer community, and it was an off-service situation. And when it was brought up by myself and the social worker, it wasn't taken seriously. And even after PSLS, even after a lot of advocating and meeting with managers and everything, nothing was done about it. Fortunately, to my knowledge, no one was hurt, but the fact that that potential was there and wasn't seen as a big deal is the problem. And so I think that if we had not just myself, but all of the clinicians, on board pushing back against that, it would make a big difference.
I know we're coming close on time, but also maybe just a little off that, but also I think connected when we look at kind of service models that are out there. Recently I was working with Fraser Health and they connected me over to a care home that exists in Copenhagen. And long-term care within the city is actually run by the municipality. And they're using a really interesting model called a values-based profile nursing home model. And what they do is they've created 9 different care homes within the city of Copenhagen, and they're based on topics like, arts and culture, nature and spirituality, multicultural communities, active social life. And one of them is for the 2SLGBTQ community. So within this system, Sotla is the name of it. It's a dedicated profile home. 60% of their residents are from the queer spectrum, but it also has straight folks who join because their values aligned. And I think that kind of points in a really interesting direction that when we see the emerging need for new models of care, particularly as this boomer generation and this bulge in our population goes up, that how can we reimagine what long-term care could look like? Is it running smaller, more dedicated homes, not just being a niche for queer folks, but being values aligned? So when I think they were talking about the spirituality one, it was really about having a lot more contemplative space for folks to do their work before end of life. Folks from multicultural backgrounds can obviously connect. Folks who are just active and don't want to be sitting in a wheelchair staring at a TV show for half the day have walking groups and all these different things that they connect in. So I think when we look beyond the scope of what's happening in our own cities and country to other countries, we can really be inspired to see what's actually possible and to create those situations so we don't run into those cases where the earlier story where a trans elder is placed in a Baptist center in the interior where it's just not a good fit, and then you get cases of bullying and so on. So based on that, I think we're pretty close. And I know folks, obviously, time of day are probably jumping back into work. Is there any last questions that we can support with? And obviously, you're welcome to reach at any stage. My email address is also included on the slides, which will be shared out and will be up on the recording. So please feel free to reach out to me at any stage. And I'm on LinkedIn and email and all the usual spots as well. Catherine. Catherine, another question?
So I just want to interrupt here and say thank you for a brilliant and passionate, informed session, both of you. Very thorough and lots to ponder. Thank you. If you need to jump off the call, please do so. And as you said, his email will be a part of the recording, will be up on the Echo platform shortly. Is there any last question that maybe you just want to direct? Otherwise, we release you to have an excellent day, and thank you for your ongoing committed work and care in your roles that you carry.